Hit the subscribe button or visit us at auau.auanet.org.
All right, like the trains in Italy, we're going to run on time. I hope that doesn't insult anybody, but any of our Italian friends, it shouldn't. It should be a compliment. Anyway, my name is Eric Rovner. I'm a urologist in South Carolina. Welcome to Contemporary Pharmacotherapy for Overactive Bladder 2023, Monotherapy and Combined Pharmacotherapy to Optimize Treatment. I want to welcome my faculty, Professor Chappell, Chris Chappell, former President EAU, and Alan Ween, Professor and former chair at the University of Pennsylvania. So I have to do a couple of mandatory announcements. This course utilizes audience response questions. To participate, you will need to scan the QR code listed. So I'm going to forward to that. So that's the QR code. If you put your phone up to the QR code, you will then be able to download the ARS system. So it should capture it there. You were also able to capture it when you came in at the entrance. If you don't have the app, the 2023 Annual Meeting mobile app is available and free to download. You'll have to generate a username and a password. All the course materials and all the slides for this course are available online. You can download them to check anything and everything to make sure that we are telling you the truth. Let's see, I have to go. AUA policy states that all planners, authors, presenters must disclose their presentation, all relevant financial relationships. We will do that as each of us present. Everybody, please silence your cell phones. No photos, video, or audio recordings are permitted. Courses are selected based on evaluation results. So when you get a notice to fill out evaluations, please tell the AUA that we did terrific, that we were great, that this was the best course you ever took at the AUA. We'd appreciate that. And then if you do the course evaluation, you will be entered into a drawing for a complimentary registration for next year's AUA in San Antonio. The way you evaluate this session is by selecting Evaluate through the credit claim process and going to the AUA 2023 mobile app, clicking on the CME button, go online, and then click the CME page. Thank you. All right. So hopefully everybody got a chance to download that QR code. Again, that's my faculty. The agenda, we'll get through all of that, believe it or not. We will talk about guidelines, both AUA and EAU, talk about monotherapy, combination therapy, some words about nocturia, and then we'll end up with future directions in pharmacotherapy for overactive bladder. Those are the learning objectives. All right, so let's move on to the pretest. So if you've all downloaded through the QR code, we're going to proceed with the pretest. So we're going to go to first question. So first question is, beta-3 agonists as a class are more effective than antimuscarinics. B, prevent dry mouth via the same mechanism as pilocarpine. C, exert their favorable effects at least in part by a similar mechanism of action as norepinephrine. Or D, are associated with bradycardia and hypotension in the elderly. So now please choose your answer. I'm not putting in my answers because I wrote the questions, so I know what the answers are. It wouldn't seem fair. Okay, well, got a few more. Okay, next question, question 2. As compared to monotherapy with solifenacin 5 milligrams, combination therapy with solifenacin 5 milligrams and mirabegron 50 milligrams is associated with which of the following? A lower incidence of dry mouth. B, greater reduction in urgency episodes. C, higher risk of symptomatic bradycardia. D, less risk of urinary retention. Go ahead and put your answer in. Your answers, the questions should still be on your phone. At least that's what they told me. Okay. Question 3. Patient-related goal achievement is A, mandated as a standard outcome measure by both the AUA and FDA for clinical trials of pharmacologic agents for OAB. B, set by the practitioner to be equaled or surpassed by the patient at a clinically appropriate interval. C, assessed at a 4-week interval following initial trial of an oral pharmacologic agent. Or D, an alternative method of assessing response to interventions for some OAB therapies. Go ahead and answer that. I feel like we need the Jeopardy music to be playing as we wait. (22, 24). All right, next question. Question 4. The risk of hyponatremia with the use of DDAVP, desmopressin, ADH, is A, increased with fluid restriction in the evening, B, mitigated by concomitant use of an oral alpha blocker, C, less likely to occur in the elderly, or D, greater in patients with a low baseline serum sodium. Go ahead and answer. The risk of hyponatremia. Okay, next question. Phase 3 studies for overactive bladder have demonstrated efficacy for which of the following agents? TRPM8 antagonists, NK1 antagonists, mu receptor agonists, or beta-3 agonists? I had to throw in one easy question. Nice touch. Nice touch. All right. I'm sorry, if you hadn't voted, go ahead and vote. All right, last question. Current gene therapy trials for overactive bladder with Uro902, A, exert their favorable effects on OAB via reduced acetylcholine release from presynaptic parasympathetic neurons. B, utilize a naked DNA vector for a portion of the MAXI-K channel. C, have demonstrated superiority to antimuscarinics in reducing urgency incontinence episodes. Or D, have shown higher rates of urinary retention as compared to beta-3 agonists. Again, gene therapy trials. All right, there we go. So we're going to move on to the talks now. I'm going to start off with a little bit of philosophy on patient goals and expectations and overactive bladder pharmacotherapy. Those are my disclosures. So we're all familiar with the definition of overactive bladder. This is a symptom-based diagnosis, urgency, incontinence, frequency, and nocturia. We're all very familiar with that. The goals for therapy for overactive bladder really depend on whose perspective we're talking about. Are we talking about the physician, us, regulatory agencies, FDA, EMEU, industry, we want to get drugs approved, or the patient? And of course, the patient is the one who's least considered in all of these, because the way we measure efficacy or the way we measure outcomes, the patients don't really care. That is diaries and questionnaires. That may or may not be what the patient is after, and yet it is what the other three entities are after. But what does the patient expect or want? And we go back to Willett Whitmore, a very famous prostate cancer surgeon from Memorial, who said about prostate cancer, is cure necessary in those for whom it is possible, and is cure possible in those for whom it is necessary. You could apply that very same thinking to overactive bladder. And let me explain further. What does the patient want or expect? And if they have a reasonable expectation, or they have an expectation, is it realistic? Is it achievable? And is it necessary for the patient to be happy with their therapy? And if their expectation is beyond what we can offer, and oftentimes it is, you see those patients in your practice, what should we do? Should we tell the patient, should we sort of sandbag and downplay their goals and tell them they're not going to get better? Should we be very aggressive with these patients? What should we do if the patient's expectations are beyond what we can do? And here's why those patient expectations are, I think, more than sometimes we can accept in voiding dysfunction. And this doesn't necessarily go for just overactive bladder, but also BPH and every other type of voiding dysfunction we have, incontinence, etc. We still don't really understand physiology of overactive bladder, and Chris Chappell is going to talk to you in great detail and give a great talk on this shortly. What is the etiology underlying overactive bladder? Is it myogenic? Is it neurological? We're not sure. There are urothelium factors probably in some patients. Are there behavioral factors? Certainly there are. And most likely it's a combination of all of these, but we don't really understand that. And what we also don't understand is if we treat successfully a patient with overactive bladder today, what happens tomorrow and the next day and the next, because the patient continues to age. What is the natural history of overactive bladder? Well, the urinary tract is not like cheese and fine wine. It does not get better with age. It either stays the same or it gets worse. We know that. Detrusor overactivity increases, detrusor underactivity increases, and comorbidities increase with aging. Those comorbidities are legion, and all of them, the ones listed here, all of them lead to some degree or can lead to some degree of bladder dysfunction. So even though we're going to talk about drugs that treat overactive bladder, all these factors extrinsic to the bladder also contribute to lower urinary tract symptoms. And that's perhaps why we don't cure a whole lot of patients. Overactive bladder is multifactorial. It has to do with lots of other factors extrinsic to the bladder that we don't treat with the medications like this list here. So what do patients expect? Is this what they expect? Do they expect after I give them one pill they're going to be cured forever? I don't think so. Some of them may think that. I think they're not particularly realistic. Do they expect to have complete resolution of their frequency, urgency, nocturia, incontinence, no adverse effects at no cost, and improve their quality of life, or not? What is a perfect result for overactive bladder? That's it. That's a perfect result for overactive bladder. Patient's dry, has no new voiding symptoms, resolution of all existing symptoms, doesn't cost anything, and has no adverse effects. Well, we're going to spend the next hour and a half talking about a bunch of drugs, and none of them have that list of cure permanently. The realities of overactive drug therapy, doesn't matter which drug you choose, have low cure rates, modest reduction in urgency frequency, modest reduction in urgent continence, and they all have some degree of adverse events, and they are a variable cost. The ABC trial, perhaps one of the best trials done for overactive bladder, compared Botox, onabotulinum toxin A, to an antimuscarinic, and the primary outcome was urgent continent episodes at 6 months. The reason I'm showing you this is not to reiterate old data. The reason I'm showing you this is the distinction between what the patients think they're getting better and the way we measure it. And what I circled here are the dry rates for the ABC trial for both groups, the Botox arm and the drug arm. And what you see are abysmal dry rates, right? So these were patients with 5 or 6 incontinent episodes a day, and their dry rates were 20%, 25%, regardless of which arm they were in. So they were fairly abysmal response rates, as we would say cure. And yet, when you ask the patient, are you better? The response rates on the PGII, very much or much better, were well in excess of 50%. So there's some dichotomy, there's some difference between what we are measuring and what the patients think is correct or better. And this is well documented in our literature. Patient goals have limited correlation with conventional measures of overactive bladder, even though we're going to spend the next hour and a half talking to you about conventional measures. Patient goal achievement, whether the patient feels they're better, shows no correlation with objective measures that we measure. So what is the patient actually asking for? And this is some research that Linda Brubaker had done a number of years ago using a questionnaire called SAGA, and I urge you to think about this. The concept is that the patient actually determines their own goal. They come to see you, you say they have overactive bladder, and you say to the patient, well, what do you want to get better at? And some might be, they want to be dry, some might want to reduce their nocturia, some may want to reduce their frequency or their urgency because it's disturbing, but ask the patient. And this type of research has been applied to multiple different areas in pelvic floor therapy, surgery, behavioral therapies, and drug therapies, and it turns out to be fairly useful. We actually did it, we applied it to the phase 2 overactive bladder, phase 2 studies in Botox for neurogenic detrusor overactivity. And basically we asked the patient, what's your goal of therapy for Botox in this neurogenic detrusor overactivity trial? And the details are not particularly important. What is important is that when you actually ask the patient what they wanted to get better at, and they could choose any of these choices, be dry, reduce incontinence, reduce other urinary symptoms, improve quality of life. What you see is this very big difference between placebo and drug. So when the patient actually chooses their own outcome, they're actually much happier. They're much better. So I urge you to think about that. So just, I'm sorry to bore you with 5 minutes of overactive bladder philosophy, but if you take home that overactive bladder is complicated, the traditional measures that we use in regulatory agencies, industry, are perhaps don't capture what the patient wants. Communication is the key, and understanding your patient goals. So I'm going to move on and briefly talk about the AUA overactive bladder guideline. Chris is going to talk about the EAU guideline shortly. I will tell you that everything I'm about to tell you is about to be updated. I'm part of the next AUA overactive bladder guideline. We just started revising this guideline. So the revised overactive bladder guideline will be probably presented at next year's AUA. We're just in the process of doing the literature search from the last AUA guideline. The chair of that committee is Ann Cameron from Michigan. So the OAB guideline has been around now for more than 10 years. The original OAB guideline was from 2012 and consisted of 151 articles from over 5,000 articles. Revised in 2014, revised in 2019, and again now will be revised in 2024. The original guideline had 22 statements, only 3 of which were standards, and back then you could only have a standard if there was enough evidence-based literature to make a statement that the risks or harms were much, much greater than the alternative. So only 3 standards came out of the 22 statements, and that's perhaps an indictment of our overactive bladder literature in general. Nevertheless, in 2019, there was an update. All the 2015 and 2012 statements remained essentially unchanged, and the major updates in 2019 were a non-hierarchical approach to overactive bladder treatment. That means that instead of starting at a patient with all patients starting with behavioral therapy and then all patients moving to pharmacotherapy and then all patients moving to third-line therapy, the update basically said that if your patient desires to move on to third-line therapy, that's okay. You don't have to fail everything else before moving on to second or third-line therapy. And then they added a category called fourth-line therapy, which we'll talk about shortly. So this briefly 2-minute overview of the AUA guidelines for those of you not familiar with it. The diagnosis of overactive bladder consists of all you need is a history, a physical, and a normal urine analysis. There are additional tests that you could order if you wanted, a urine culture, post-void residual bladder diary, symptom questionnaires, but they're not required. And then on the initial evaluation of an uncomplicated patient, you do not need to do cystoscopy, urodynamics, and renal and bladder ultrasound. They're not needed. And then patient education. Dating way back to the first guideline, no treatment is an acceptable choice for some patients. I think that's very wise. Some patients just want to make sure they don't have bladder cancer. They don't need a drug. They don't need sacral neuromodulation. They just want to be reassured. First-line treatments are behavioral therapies. You're familiar with those. They can be combined with antimuscarinics. The guideline does not have any preferential treatment for any of the oral pharmacotherapies. There's no hierarchy or preference for any of these, but there is a class warning for both beta-3s and antimuscarinics in the frail, elderly, and demented patients. ER formulations, extended release formulations, should be preferentially prescribed over IR formulations when available. And in 2015, beta-3 agonists became available in the US. They were not previously available, so they became an option in 2015 and remain an option today. Again, same caution in the frail elderly, similar to antimuscarinics. In the 2015 update, the definition of an adequate trial of pharmacotherapy and behavioral therapy was outlined. A pharmacotherapy approach should be given about 4 to 8 weeks of drug, and behavioral therapy about 8 to 12 weeks, which actually makes sense if you think about muscle physiology and how pelvic floor physiotherapy should work, and muscle physiology, 8 to 12 weeks, 3 to 4 months should be a minimal trial for behavioral therapy. All the third-line therapies remain the same. We'll have to see whether on our latest update that will be the case. And then the fourth-line treatments were added at the last guideline. They include indwelling catheters in refractory patients, including transurethral suprapubic, and of course augmentation cystoplasty or urinary diversion, now rarely ever used for severe refractory and complicated overactive bladder. That's the current algorithm. Obviously you can't read it, but it'll be on the slide set when you get your slides if you download this set of slides. Thank you very much. That's our lovely bridge in Charleston. I'm going to turn the lectern over to Professor Chappell. Thank you.
Thank you very much, Eric, and it's a great honor and pleasure to be speaking here today. I think it's often quite sad that we're looking at the same information. In many ways, our organization should be working closely together because it's the same data. The AU guidelines are updated every year, but in this area there is very little new change, to be honest. All the guidelines, the AUA guidelines likewise, are based on the Cochrane principle of PICO. You look at the population, the indication, and the comparators. The only difference with the AU guidelines is they use the grade process. So you don't have A, B, C for information. You either have it as good or weak, strong or weak. Okay, these are my disclosures. And just to mention, as you can see, the guidelines have been updated every year. They are actually accepted now by numerous worldwide bodies. 74 organizations worldwide use them as their standard. And certainly if you look at our guidelines, and by the way, they're freely available on the web. You don't have to be a member of the AU to download it. If you just go on to EAU guidelines and then whatever topic you want, the whole of urology is covered with an up-to-date guideline. If you look at the history, physical examination, diaries, urinalysis, and all the other points, just as you've heard from the AUA guidelines. And this is the format. As you can see, basically, if you're looking at symptom scores, there's strong evidence suggesting their use. Likewise, if you're looking at recommendations, urinalysis, of course, should be used. And clearly, the evidence for looking at post-voiding residual is very strong because, of course, you can have storage symptoms or incontinence if you're not emptying your bladder. That goes without saying, doesn't it? If you look at the frequency volume chart, I don't know how many people use this. Everybody who works in this area recommends the use of this, and you can't practice modern urology without a bladder diary. How do you know if somebody has got nocturnal polyuria? Except by guessing. How do you know it's more than a third of 24-hour production? You hear more about that later. And how can you actually work out the functional bladder capacity? How can you actually work out the voiding efficiency? In other words, what the residual means relative to the functional capacity, which is the volume voided plus the residual. I like to call it the voiding inefficiency, not efficiency, because 40% is the optimum, and the higher it goes, the worse it is. So it should be inefficiency, if you ask me. And of course, when you're thinking about anything to do with the urinary tract, you need to think about a normal functional capacity. I've defined below how to measure a functional capacity, and a reduced functional capacity, which is obvious. And of course, we always have to think of other conditions such as CIS and so on. And then, of course, the reduced anatomical capacity. Now, if you've got somebody who's got very severe symptoms, and obviously you'll be cystoscoping them, it's very useful to measure the capacity under an anesthetic. Because if it's less than 250 mils, in my experience, whether it's with painful bladder syndrome or whether it's relating to post-ketamine disorders, then the likelihood of conservative management is very poor of it being successful. So if you move on now to looking at pad testing, I don't think many of us use that routinely, but it's a valuable adjunct and there's good evidence for its use. Of course, biomarkers have been used. You may see that in the literature, but to be honest, it's a lot of nonsense, most of them. Bladder wall thickness, of course, you're talking about millimeters and depends how distended the bladder is, and nerve growth factor and others have been basically found not to be something you can measure. There aren't any actual tests which have been developed for looking at NGF in the urine, and there was a whole plethora of papers, and if you wonder why they've all disappeared, that's the reason why. One particular study where was a company, an industry-sponsored one, where they actually froze samples. They found there was a 10 to 3-fold difference in the same sample when measured. So if you like, that was a no-brainer. So if you actually look at other aspects like do not formally use biomarkers, there's strong evidence for that. Okay, so if you come on to urodynamics, certainly that is a very valuable adjunct. But remember, urodynamics is a frequency-volume chart, a careful history, the post-Vorning residual, and then pressure flow studies. And you have to use these according to the individual patient, and you always have to ask yourself how it's going to alter your management. So indiscriminate use of this is not necessarily useful. And secondly, badly carried out urodynamics by somebody who doesn't know what they're doing with a lot of artifact, it actually can be worse than not doing it at all, because you may go on the wrong track. And certainly in my country, despite people's enthusiasm, when we do central read studies, 30% of the urodynamics have to be discarded because of poor quality and methodological errors. So I think it's fair that good, well-conducted urodynamics can be very useful. So coming on to disease management, of course, we've already heard from Eric the importance of behavioral techniques, fluid restriction and so on, and the overall disease management. And as I say, you can look this up, pelvic floor training, if you've got mixed incontinence, for instance, and of course, if you're coming on to other things such as electrical stimulation, the evidence for that's weak. If you look at the various drugs, you can see that the EAUs tried to compare them, and essentially the antimuscarinics are all very similar. And we did a study a few years ago looking at them, and it all depends on what you're looking at. But overall, if you're using this type of approach, there's no doubt the antimuscarinics are more effective than the beta-3 agonists. Essentially, all the antimuscarinics are very similar. There's a lot of marketing involved. There may be difference in side effects, and the same goes for the beta-3 agonist, to be honest. A class effect, and there may be nuances in terms of toxicity, potentially minor toxicity, drug-drug interaction, and so on. So there's good evidence that anticholinergics are certainly effective and a standard of care as first-line therapy. And of course, we are all familiar with the fact that in the elderly, particularly you have a problem with mentation, post-stroke, dementia, and so on, the anticholinergic load, if you've got a diminished cerebral function, may have an impact. But 30 years down the line, nobody's been able to crack whether there's a difference between the different drugs, although certainly some of them, there seems to be evidence that they're possibly safer than others. Mirabegron and beta-3, and of course Vibegron, both are within the EU suggested as first-line therapy. There's strong evidence that they're effective, and certainly nobody's done a head-to-head comparison directly to date. So if you're looking at alternatives to pharmacotherapy, you can see there's all the other aspects, bladder training, tibial nerve stimulation, which is thought to be slightly better maybe than drug therapy, but very labor intensive if they're having to come up to the hospital regularly, and certainly strong evidence that you should be obviously looking carefully at the patient and assessing them appropriately. What about drugs for stress incontinence? In Europe, duloxetine is licensed but rarely used because of the side effects, because of its central mode of action, even though the companies introduced it, tried to persuade everybody who was acting on honest nucleus at the sacral spinal level. But seeing a higher dose is used for stress incontinence and used for depression, I'll leave you to make your own decision as to whether it's acting centrally or not. And certainly the side effects are those you'd accept from a centrally acting drug. As estrogens Certainly, there is some evidence that they can be effective dealing with urgency in the postmenopausal female. There is no evidence that they help with stress incontinence, and of course estrogen therapy can be invaluable in those consequences if you've got a chronic problem postmenopausally with urinary infections. There's good evidence from gynecological literature can be effective for that. Mixed incontinence, again, it's a matter of clinical judgment, and the evidence is fairly weak except for anticholinergics and possibly the beta-3, but again it's for predominant storage problems rather than stress urinary incontinence, in other words the OAB symptoms. Desmopressin we've already heard about. There's concern about, as you'll hear more later, about possible side effects, particularly hyponatremia, but potentially if you carry out careful assessment of the biochemistry a week after starting it, and then a month later, and you pick out the patients who are susceptible. Remember that women are more susceptible to hyponatremia than men because of renal management of it, but it can be very helpful with nocturnal frequency. But of course with polyuria you've got to be careful not to overload them. Onabotulinum toxin, remember that the various Botox agents have a different structure, and of course this is Botox, onabotulinum toxin, good evidence for its use. Sacral neuromodulation likewise, and of course refractory overactive bladder. You need to think about other aspects, but certainly there's good evidence that not rushing into using laser and so on the vagina or on the base of the bladder until we have more evidence. Augmentation cystoplasty, rarely used nowadays, but can be, and this would fit into the fourth line the AOA's mentioned, can be invaluable if you've got a neuropathic patient, particularly if Botox will wear off, and so the worry is you may have a silent bladder that's going off with a high pressure, and so that's to be borne in mind. But of course we have to bear in mind that there are the side effects of augmentation cystoplasty. So I think I'm just about on time. And I'll move on to the next talk if you can bear putting up with me for another 20 minutes. I'm just going to reset that. Okay, so physiology. Urodynamics is now 50 years old. That's when the International Continence Society was founded in the UK, and Turner Warwick, who developed urodynamics at the Middlesex Hospital, got the idea from Earl Miller at UCSF. And the reason I'm mentioning this is the International Continence Society was both multidisciplinary and also it was trying to deal with terminology. And it's very sad, 50 years down the line, we still haven't got it cracked. We still believe that you can make a diagnosis based on symptoms. We still use the terms, as I'll show you, in different ways. Again, these are my disclosures. And this is what was described by Turner Warwick: the bladder is an unreliable witness because the symptoms are not disease specific. Patients report them in different ways, and we all come up with our own interpretation, don't we? And of course, lonely tract symptoms and BPH, a term still used. What is BPH? What actually brings patients with BPH to see you? It's usually storage symptoms, isn't it? Getting up at night, getting caught short, going out to the shopping mall. It's not actually they're going into retention. Only about 2 to 3% of men go into retention over a 5-year period, as we know from the VA study. And of course, we then talk about voiding dysfunction, don't we? But many people talk about it when they mean storage dysfunction. Failure to store, which is overactive bladder. Alan Ween was the key person in actually developing the concept of overactive bladder as a non-specific symptom complex. Not a diagnosis, but a way of categorizing patients. Then, of course, you've got the voiding dysfunction, delay, poor stream, failure to empty, haven't you? But if you say voiding dysfunction when you mean storage, don't you see how confusing that is? Because at the end of the day, and this is a pivotal slide, look at it, men and women. Can you see any difference in the frequency of the symptoms between the two sexes? And I'm sorry the boxes haven't come out in different colors, but just take it from me that men and women are shown there next to each other for each of the symptoms. There's absolutely no difference. And women clearly don't have prostates, and men certainly don't have problems with vaginal prolapse. So if you think you can diagnose somebody as having BPH because they're male on symptoms, without further evaluation, you can see the problem. So it's an empirical diagnosis, overactive bladder, and it's not the same as bladder overactivity, as I'll show you. An urgency, which is a sensory symptom, which is actually perceived in the brain, and we all experience that if you've had a lot to drink and you get home, put a key in the door, and you have to make a rush for it. But of course, with overactive bladder, that's common. That's what drives it. There has been some terminological inexactitude because the FDA understandably said you couldn't easily measure it, and people therefore talk about urge incontinence. But that's a misnomer because urge is normal. That's a normal sensation, whereas urgency is a pathological symptom. So you may wonder why these strange Europeans talk about urgency incontinence and not urge incontinence. That's the reason. And that's why the ICS has defined it that way. And of course, if you go more often, you pass less each time you go. If you're doing it at night, it's nocturia. And of course, in a third of women with severe overactive bladder, they may have incontinence. And if you look in men, and of course men rarely get incontinence unless they've had a radical prostatectomy or unless they've got chronic retention with overflow, then you can see that even in men, as they're getting older, you've got more overactive bladder symptoms in women. And that sort of fits what we know clinically, doesn't it? So, urgency is a sensation, and all sensations are perceived in the brain. This leads on to the next discussion. What is the target of therapy? Now, a lot of people think the target is the bladder, don't they? But please reflect on that, and I hope I can prove to you it isn't the target. Because that's what we know now. We may be wrong, I may be talking nonsense. And of course, urgency is different from the normal urge to void. Then of course a fly in the ointment is you get onto bladder pain syndrome, or so-called interstitial cystitis. Again, it's a symptom, but it's a pain symptom, isn't it? Which causes frequency, although there can be overlap of the two conditions because they're not diagnoses, they're descriptions, and we're all familiar with that. We mustn't forget, of course, in men, if you've got significant storage symptoms, it affects your quality of life, and there's no doubt that the worsening of lower tract symptoms you see along the bottom, and you can see never, mild, moderate, severe, are also related with increasing age to the level, as Ray Rosen showed many years ago, of erectile dysfunction. So, of course, there is an overlap there. Ty Halt was one of the founders of the ICS from Denmark, and Halt's rings, and this is a modification of that. And the idea here is, you can see this is looking at men, and of course, as we all know, a proportion of men increasing with age get histological BPH. But then within that, they may actually have obstruction, BPO, they may have underactivity, they may have other causes for the symptoms, whether it's CIS or something else, and you can see, therefore, you have to bear this in mind. So if you want to say just because you're male and you've got symptoms, you've got BPH, you see you might be missing the boat. And of course, around every set of symptoms, you have to think of all of the other aspects, the endocrine factors, the heart, the kidneys, and everything else that's going on, and bear that in mind. And if you do the same for women, of course, here you have a similar scenario. Of course, in women with a weak outlet, because their bladder necks, and 40% of nulliparous women don't provide continence. Men, of course, have a bladder neck to prevent retrograde ejaculation or emission of semen, and a prostate. And of course, the distal sphincter in men is akin to the urethral sphincter in the female urethra. But of course, women, you're talking about stress incontinence, urgency incontinence, and of course, all the other conditions that can affect bladder behavior, just as in men. And of course, you've got all of the other factors, neurological, renal, and so on, as I've mentioned for men. So, the strength of a diagnosis, it helps you to understand what the patient is concerned about. The weakness is if you start using a symptomatic diagnosis as the ultimate diagnosis, which dictates all of your treatment, without actually considering other factors, then you might come into trouble. Are there two types of afferent sensation? Yes, there's pain, and of course there's urgency and potentially bladder overactivity on urodynamics. Painful bladder syndrome, of course, as you know, we don't really understand why people get it. thought of a gag layer being absent in the bladder, as well as maybe mucosal abnormalities, and of course that's why we use intravesical installation of hyaluronic acid and so on to restore the gag layer. Urodynamics, just to emphasize, if you carried it out without standardization of equipment or technique, you could have problems. And we're all familiar, this is just showing the principle of the urodynamics, which you're familiar with, and video urodynamics from the Latin video videre, to see, nothing to do with a video machine, all to do with the use of contrast, and of course a classic case of detruse overactivity. As you know, there is no specific pressure rise to define detruse overactivity. It's a pattern you see. They used to use 15 centimeters water because it was felt that that was just getting above the filtration pressure of the kidneys. Subsequently, from the Whittaker test, that was shown maybe not to be the case. So what are we talking about from a functional point of view? Of course, the terminology has been defined by the International Continence Society. Overactive bladder, urgency with or without urgency incontinence, usually with frequency and nocturia. I've shown you the diagram. And of course, detruse overactivity, shown urodynamically, can be in a patient with no neurological disease, although most are idiopathic, but doesn't mean they haven't got a latent neurological disease. And of course, it increases with age potentially because all of us, as we're getting older, start getting neurological dysfunction. And you can see this is data from Bristol, showing you can see in women, pink, men in blue, not wishing to be sexist, but you can see that women who are incontinent, only 58% have overactivity, even though they've got urgency incontinence. And in men, of course, with the strong outlet, it's 90% of men who have incontinence have detruse overactivity. And for dry, you can see it's 44 and 66. So which definition of bladder overactivity? A symptomatic diagnosis? Sure, if it helps in starting treatment. I'm not suggesting you do urodynamics on everybody to start with. You only do it if you're trying to find out more in the more complex cases. Ambulatory urodynamics is a misnomer because it's not really ambulatory because the catheter keeps falling out the rectum. So it's actually walking around a laboratory with catheters in. And of course, 90%, 80 to 90% of normal people will have increased pressure rises because urodynamics has never been categorized for ambulatory, only for the laboratory provocation cystometry. And so you can prove, if you can't find urodynamic overactivity, people do ambulatory, find it, and then treat the patient, which always strikes me as rather silly, because they should have done it anyway. If you're then looking at the function of the detruser, there's no doubt that it is cholinergically mediated. I'll come on to animal studies in a minute, but it is a counsel of desperation often, trying to use an animal to predict outcome in the human. Firstly, because the models which are used are not anything to do with the human situation. Putting acetic acid or cyclophosphamide in a human bladder would cause a hell of a problem. Putting in an animal bladder certainly doesn't recreate overactive bladder, and certainly if you're looking at the innervation of the animal bladder, the rodents and so on, they have a non-adrenergic, non-cholinergic innervation. So, of course the detruse is cholinergically innervated, and it seems sensible that's the target for therapy, isn't it? But is it? Certainly over the years, many of us working in the field of pharmacology have come to the view it's not as simple as that, and it may well be the sensory system. And don't forget that the innervation of the rectum and the bladder is the same. You all see that with Cauda equina syndrome, where you get constipation and underactive bladder. And if you look at this, you can see this is work from Belgium, and they showed that if you've got rectal distension, it increases the sensation of bladder filling. And of course, conversely, if you've got vesical distension, it decreases the sensation of rectal filling. There was talk a few years ago from Coulsett and others about micromotions, but it's largely been disproven because if you take a non-innervated, non-perfused guinea pig bladder like here, of course it'll do things like this because it's dead. It's got no blood supply, and so that doesn't seem to be entirely sensible. Now this is an important slide. Were you aware that the urothelium has a metabolic rate 4 times that of the detrusor muscle? Were you aware that the urothelium releases neurotransmitters when you stretch it? Now, you're familiar with physiology. If you scratch yourself, you get a white line and then you get a flare, antidromic transmission. So as you distend your bladder, the principle of receptive relaxation is you also get intrinsic production of various mediators that actually act locally to prevent the bladder contracting. One of them is nitric oxide. Now, as you know from your physiology, nitric oxide is the best relaxant. Okay, you can say Chappell's talking rubbish, but there is an animal model using blood clot, which causes intense overactivity in a rat bladder. Now, I'm afraid all of us have seen clot retention, haven't we? But is it retention, or is it a poor patient after an operation who's got clot in the bladder and it's intensely overactive, isn't it? They're getting a lot of pain and discomfort. You wash out the blood clot and they all get better, don't they? And that's because it's absorbing that nitric oxide and the bladder becomes dysfunctional. An example. If you actually look at this, you can see that there's a dense suburothelial plexus, and you also have these things which were only described about 20 years ago, the interstitial cells, like the interstitial cells of Cajal. Now, those interstitial cells have a cholinergic innervation. The sensory nerves also have a cholinergic innervation. So bear that in mind. It's not just the detrusor muscle. And this is a slide from Karl-Erik Andersen. Of course, the detrusor muscle is cholinergic. It's important. You've got the non-neuronal release of all of these neurotransmitters, and you've also got those suburothelial nerves. And you can see a sensory nerve there, which is acting under the influence of acetylcholine. And you can see these suburothelial sensory nerves, and you can see that it's quite a complex setup. So when you hear about people trying to tissue engineer the bladder, when you're dealing with this complexity of different structures, you can see it's nonsense, because unless you can recreate and innovate a huge number of different types of cell, you can't bioengineer something. All you can do is produce an epithelial substitute. And the study which did report that in the Lancet came to that conclusion. And these are the interstitial cells. You can see they stain up for ligands, and this is McCloskey, who is basically working in Belfast. She's a leader in this, and you can see that's acetylcholine on these cells. So it isn't limited to just focus on the periphery. Let's think about the center. Were you aware that if you put capsaicin, which is like chili, but 16 billion times stronger, into the human bladder, it causes retention for 6 months? Now, capsaicin only acts on sensory nerves. It's extra hot chili. It degranulates explosively sensory nerves, and that puts the bladder totally into retention. Another drug is racinophrotoxin, which is even more potent, and you can see that they tried to develop that for clinical practice, but it was absorbed to plastic, so it never actually went anywhere. So let's think about what happens from the bladder. As you're sitting there, sensations going up to your brain, through periaqueductal grey matter, and it's reaching the cortex. All the time that you're sitting there, that's happening. And what's happening is that the cortex is having an inhibitory effect on the pontine micturition center. Anxiety, coming up to exams, dementia, frontal strokes, aging, all have an effect on that cortical control. And when you give permission to void, which is when you get that threshold for urgency when it comes to your perception, if you think about it, you can feel how full your bladder is, can't you, if you actually think about it. But when you decide you have to go, you've got to go if you've got urgency. And of course, then the pontine micturition center can void, leading in normal situation to coordinated emptying of the bladder, contraction of the bladder, and relaxation of the sphincters, so you don't get detrusor sphincter dyssynergia. And you've been able to show with studies looking at functional MRI that you've actually got parts of the cortex lighting up. But the trouble with these studies, difficult, is because patients are lying flat in an MR scan and trying to void, and it's not a physiological situation, putting aside the bashful voiding and so on. So what are the potential targets? I don't think drugs with a central action are going to be particularly effective because of the side effects. We'll hear more about that later. Drugs primarily looking at the mucosa signaling, again, very complex. but possibly, and certainly there you're looking at Botox and other agents which you inject in that area and at the suburothelial plexus. So basically you need to think about these different components when you're trying to treat the patient. And of course there have been many drugs that have come along. You can think of over a dozen which have gone through to phase 2 and then failed because they've been based, and there's one recently, a purinergic agent, based on fantastic animal studies showing great potential effect, but of course, as I've said already, that doesn't equate with man. And certainly what you're looking at, if you're looking at the feedback locally, is you've got activation of sensory neurons and you've got chemical neurotransmission I've mentioned locally, you've got the urothelial effect, and you've got this sort of situation where you've also got these non-neuronal release of these neurotransmitters. So there are various drugs, and of course if you're looking at the myocyte signaling, we're all familiar with the use of very different agents. PD5 inhibitors are potentially acting more by the sensory system, beta-3 agonists on the sensory system. As you've seen, the marketing says, because the FDA and the other regulatory agencies say that a drug such as a beta-3 relaxes the bladder. But does it increase residuals? So is it acting on the detrusor to relax the bladder? Of course it's not. It's acting to relax the bladder by the central pathway. How does sacral neuromodulation work? Does that work on the bladder? How about posterior tibial nerve stimulation? Can you see why I'm saying what I'm saying? Okay, you can say Botox works on the bladder. Of course it does. But when I did the phase 2 studies, and Eric's done the same studies, and phase 2, you basically see that you've got a threshold, 150 units. You go above that, you get more retention, no greater effect. So it's a bystander effect, the effect on the bladder muscle. And none of these animal studies have ever produced anything therapeutic in this field. Viagra, the volunteers got erections with a drug designed for pulmonary hypertension. Beta-3, failed anti-diabetic drug. Anticholinergics, atropine. 5-alpha reductase, Dominican Republic, congenital defect. Okay, so sacral neuromodulation, Rick Schmidt, I'm just mentioning, involved in that, as you can see with Emil Tanago there, the patent for Botox, which he took out when he was at Denver. And certainly there's clear evidence that what I'm saying is reasonable. This is work from our lab using a PITH model where we're measuring real time, gave Botox, and you can see the reduction in sensory neurotransmission over the course of a short period of time using Botox. Of course, if you look at the beta-3, they act on sensory mechanisms, and that's been clearly shown. They don't increase residuals. So, I will leave you now just to say that what we know is what we know, but there's an awful lot, and this is the slide from Alan, the Journal of Negative Data. Do you actually see the negative data with all of the new treatments we have? You always see a great aplomb as they introduce a new treatment, and then they disappear, don't they? It's the same in this field. Don't be misled and think you can diagnose a patient just on a history. Don't think you're just trying to make the bladder stop contracting when you're treating them, because that increases residuals. Of course it's an effect of anticholinergics. Of course it's an effect of Botox. But you'll also be seeing with Botox, a paper that's in preparation at the moment based on the pivotal studies, that it's age-related, the retention. Around the age of 40, it's about 1% in the paper. And so certainly, I'm not suggesting you shouldn't counsel patients about ISC, but just bear in mind that you're looking at a sweet spot to hit the sensory bit, because urgency and overactive bladder are sensory-driven problems. Thank you very much.
We'll now have Alan Ween present on monotherapy for overactive bladder.
So good afternoon. Okay, so let's treat with pharmacotherapy. Potential conflict of interest advisor. These are all good sources. Now you have all the slides. There are 2 slides that I added a few weeks ago that you don't have. I'll tell you which ones they are, but you have all the rest. documentation for each slide basically is there. These are three that I found very valuable. As Eric said, the overactive bladder guideline from SUFU and AUA is being revised. It'll be ready next year or the year after. Whoa, this is a lot too complicated. So after you get done diagnosing, basically you treat, and you treat with what? Well, first line behavior modification, second line oral monotherapy, third line neuromodulation or Botox, fourth line augmentation cystoplasty, et cetera. What is it we're trying to do? These are the potential management strategies for overactive bladder or detrusor overactivity, and we'll be concentrating mostly on number one, although all these in a different situation actually work. So the ideal drug, as Eric said, it blocks urgency, it blocks detrusor overactivity, it doesn't affect voluntary voiding, and there are minimal safety issues. Uroselectivity is and always has been the key. Unfortunately, there's no drug that's totally uroselective. These are the treatment goals. Remember that, as Eric said, the patient expectations have to be realistic, and a realistic goal is not cure. As Chris pointed out, it's actually symptom improvement. These are the metrics that are measured. Easiest one, urgency urinary incontinence episodes. Pretty easy to count. People don't forget when they wet their pants. Urgency, sort of difficult, and nobody really knows how to define it very well to every patient. Urinary frequency, okay, pretty easy to count. Volume voided, obviously should go up with every treatment. You'll be surprised to see how little it actually goes up. Nocturia, unless the patient gets up with a severe urge to void at night, or urgency, because urge is a normal sensation, then the overactive bladder drugs are not going to work on nocturia, and most of them improve quality of life. What about behavioral therapy? Well, these are all the spheres that go into behavioral therapy. Now, the guidelines say start with behavioral therapy. I don't believe in step therapy. I think it's a waste of time. I think that it's disadvantageous to patients. I don't see telling them behavioral modification and telling them do all these things, come back in 6 weeks, and if you're not better, I'm going to give you a drug. You know, I use drug therapy and behavioral modification together. And basically the reason is that if you use behavioral modification and drug for both men and women, that you will find that the two together give you a better result than either one alone. These are the additions from the EAU guidelines in general terms, and as Chris said, I would recommend these to you. These get revised every year, and although there aren't many changes, there are some. Reducing caffeine can reduce symptoms of frequency and urgency. Reducing fluid intake by 25% may, you see it says may, doesn't always. Obesity's been found to have a risk factor, at least in women, but its relation to other OAB symptoms is uncertain. There's weak evidence for smoking cessation. Let's take a look at the antimuscarinics. I'll show you some pretty pictures. The antimuscarinics can work either on the afferent innervation or on the efferent innervation, filling and storage and emptying. Now, what do the antimuscarinics decrease? What's the main symptom of overactive bladder? Urgency. That's what the antimuscarinics decrease. When does urgency occur? Does it occur during emptying? Nope. It occurs during filling and storage. So that's where the antimuscarinics work in the doses that you and I use them to treat overactive bladder. So in the usual doses, they do not affect emptying in patients with overactive bladder, even those with moderate bladder outlet obstruction. In the higher doses, they can produce retention. And here's a nice diagram by Carl Eric Anderson. This is the therapeutic window for OAB. As you increase the dose, you begin to affect the voiding contraction. It depends on the concentration of antimuscarinics. This is the chart used by the International Continence Society to rate the drugs. What 1A means basically is that there have been double-blind placebo-controlled studies, and 1A means in the opinion of the society they work. So look at all the drugs here, the antimuscarinics. These two are in a separate category because they have actions in the laboratory, not clinically, that are in addition to antimuscarinic actions. You see the beta-3 agonists basically both get a 1A recommendation, and you see that The phosphodiesterase 5 inhibitors also get a 1A recommendation for LUTs, Botox, and you see that for nocturia, basically desmopressin gets a 1A as well. So these are additions from the AUA guidelines that basically Eric has shown you. Basically, behavioral therapy, first line, yeah, I use them both together. You can use either an antimuscarinic or beta-3 agonist. And if you look through these, you'll see that these are all Eric mentioned. Don't use antimuscarinics in patients with narrow-angle glaucoma unless the ophthalmologist says, I've treated it and it's okay. Obviously, patients that have significant outlet obstruction, be very careful with the antimuscarinics and be very careful with both drugs in frail patients. How do you compare results? Well, there's not a good way because everybody uses the results that's favorable to them, right? As Chris said. So be very careful, compare apples to apples, oranges to oranges. Remember that medians are different than means. For some reason, median changes for overactive bladder drugs are generally higher than mean changes. Don't mix the two. So how do you get a baseline? How do you get a baseline if there's no head-to-head studies? And no one's going to do head-to-head studies. Well, I think comparing percents and then calculating a drug-placebo ratio is a good way to establish a baseline. It's not perfect, but you can do this with basically simple mathematics. So let's look at the antimuscarinics. And these are mostly median results. Okay, urgency urinary incontinence reduction. Whoa, look at the placebo effect. That's high. Anybody realize it was that high? Well, probably so, but you don't think about it because this is what the patient sees. Here are the drug-placebo ratios. Urgency episode reduction, okay, 30 to 50% with a placebo ratio of that. Here's the drug-placebo ratio. Frequency reduction, not very much, really, right? And here's the placebo effect. So the drug-placebo effect is here. All the drugs improve quality of life. These are the side effects. You're all familiar with these. Yep, some placebo patients do get dry mouth, constipation, etc. There was a flurry of information. Do the antimuscarinics affect cardiac function? Not in the clinical doses that we use. Cognitive dysfunction, you'll see I have some slides about that. I think the only drug that's been definitively proven is oxybutynin and immediate release. And the EA, you can find that with a level of evidence 2 in the EAU basically guidelines. So anticholinergics and cognitive ability, 2 big studies. Increasing load, significant decline. Significant decline in the mini-mental status examination associated with the use. The greatest risk basically in these patients. 2 important papers. This is the AUA SUFU White Guideline. Very good, published in 2022. Really nice authorship. This is the American Urogynecologic Society. They both say the same thing. Be very, very careful of anticholinergic total load in patients that you treat with an antimuscarinic for overactive bladder. This is actually from 2016. This is when this first appeared in JAMA. And this is a good summary of this side of the argument. The use of anticholinergic medication is associated with increased brain atrophy and dysfunction and clinical decline. Thus, use of anticholinergic medication among older adults should be discouraged if alternative therapies are available. So this is the issue. Most articles support this, not all. Supportive articles cite the total antimuscarinic load. The drugs are not separated, as Chris mentioned. So in other words, they don't separate out trospium, which in a normal individual doesn't penetrate the blood-brain barrier. They don't separate darifenacin, which is pumped out by the PGP system after it crosses the blood-brain barrier. So the studies are not perfect. They certainly suggest, though, to me, that, wow, if you have a choice, be really careful with these drugs. So these are the recommendations from the EAU for antimuscarinics. You basically have seen these before. And by the way, when you hear a series of talks, if you hear the same thing twice, it's probably true. So these are the EAU. Consider extended release formulations. If the treatment's ineffective, either raise the dose or use a different antimuscarinic or add A beta-3, this says mirabegron because they never changed it from the time this guideline was formulated. Okay, EAU, very clear, big italics, my italics. No anticholinergic drug is clearly superior to another for cure or improvement of OAB UUI, just as Chris said. This is the way they're listed in the guideline, and I've just put this in red. It's not in red in the guideline. Most patients will stop anticholinergics in the first 3 months. I'll show you that in just a second. You can escalate the antimuscarinic drugs. Basically, higher doses are apt to be more effective, but they're also apt to produce more side effects. So, how do you level the playing field? As I told you, I think it's reasonable to take what the company submitted to the FDA, okay? Take the percents that they list, do a drug placebo ratio, and compare them. And you'll see, as Chris said, there's not a whole lot of difference between the drugs in the two classes. So here, let's take, as an example, solifenacin and fesoterodine, because the PIs have been recently revised, okay? This is Soli-5, this is efficacy. These are for a decrease in incontinence episodes. This is efficacy, this is placebo. Here's FeSO4, efficacy, placebo. This is Soli-10, efficacy, placebo. My, look at that. Not much different than Soli-5, is it? Here are the two studies that were submitted. Here are the two studies that were submitted. FeSO8, drug, basically, and placebo. So here's the drug placebo ratios, okay? Two studies on Soli-5, 1.8, basically 1.5. Three studies on Soli-10, and you can see that not a lot of difference in Soli-5. Here's FeSO4, and here's basically FeSO8 with the actual efficacy rating. So this one is 2.30. Well, why is it 2.30 and the rest are in the ones? Well, if you look at the efficacy rate, the absolute rate, it's not a lot of difference from the rest. So what's that mean? It means that in this particular study, for whatever reason, they had a low placebo rate, right? So what about the placebo effect? Well, placebo effects are really high. Here's a bunch of results, 41% to 56% symptomatic improvement or cure in the Cochrane review. Here's another publication, urinary incontinence episodes per day, placebo. So really pretty incredible. Frequency, voided volume is the least placebo effect. Here's another series, placebo, basically for urinary incontinence episodes for antimuscarinics. Basically, this is for stress incontinence. You see it's really the same thing. This was with duloxetine. This is a bar graph. Shows the same thing. Okay, here's the drug effect. The most effective one is oxybutynin. This is the placebo. So now think about this for a minute. What's the actual drug effect? Okay, is it this or is it the difference between this and this, right? So the actual drug effect is the difference between the drug and the placebo. Is the placebo effect sustained? People say, well, no, it's not. Well, so consider this. There are agents that do a continuation study. So I put you on a drug, it works. There's a whole bunch of people like you. I take the ones in which it worked, I extend it out for a year, okay? The rate in which it worked initially is the same at the end of the year. Now, initially, I showed you a large percent's due to placebo. If the placebo effect goes away, then the total effect of the drug should be much decreased by the same rate, right? In other words, it should be drug minus placebo. Guess what? That doesn't happen. It's the same. So the placebo effect, I think if you treat the patient right, or encouraging, if you have a bright, cheery attitude, et cetera, you follow them carefully, I think the placebo effect is sustained with these drugs, and it's the same at the end of a year in the ones in whom it worked originally as it was at the beginning. And do we really care? And what does the patient see? The patient sees the end results. The elderly, this has been over, you have to be careful. Assess the anticholinergic total burden in the elderly people being considered for anticholinergic therapy. Long-term anticholinergic should be used with caution. This is the AUA guideline, the EAU guideline. It'd be interesting to see what the AUA comes up with. You can use antimuscarinics in men. you can use to significantly improve storage symptoms. They can be associated with an increased PVR. The EAU sets the limit at 120. If somebody has a residual of 120, be real careful using antimuscarinics. Below that, it's okay, just try it out. And if you use it with an alpha blocker, it's more effective in reducing the filling symptoms and the storage symptoms than either one alone. How about neurogenics? Well, they work in neurogenic patients as well. And this is the EAU, use antimuscarinic therapy as first-line therapy for neurogenic detrusor overactivity. This is from Dave Ginsburg, excellent AUA guideline on neurogenic lower urinary tract dysfunction. You can use antimuscarinics or beta-3 agonists or a combination to improve bladder storage parameters. So what happens with antimuscarinics after a while? Whoops. Statistically, they go down because in many people, they just don't last. So this is 12 months, and you can see the results are pretty dismal. Why is that? Well, this is basically one compilation that I did for one article that I did. In general, these are the reasons. OAB specifically, the big one, unrealistic expectations, okay? It's not that they don't work as well as you told them they were going to work initially. This is a statistical analysis from the EAU guidelines because of not enough efficacy, because of adverse events, because of cost, other issues, and unreal expectations. Basically, the reasons for discontinuation are higher in the younger population, it's lower with extended release, and lower for some reason in women. The beta-3s, mirabegron, the first one, so the mechanism of action was figured out with this. Initially, they thought it was the direct evidence on smooth muscle. The activation of adenyl cyclase yields cyclic, actually it's GMP, and ongoing bladder potassium channels may be activated, causing hyperpolarization. And then afferent inhibition was suggested as well, just like with antimuscarinics. And then there was a suggestion of prejunctional receptors which downregulated acetylcholine release from cholinergic terminals. I'll show you some nice pictures. This is from the book Incontinence. So they definitely improve urgency, so they have to act during filling and storage. They definitely improve urgency, as I said, so they act during filling and storage. There's some thought that, well, they also act to decrease spontaneous bladder activity if indeed that exists in the smooth muscle. Now, both mirabegron and vibegron get a 1A effect. What does mirabegron do? Well, again, this is some of the prescribing information, so I think it's, it has to be as good as any result. So this is mirabegron 50. There were 3 studies submitted. So this is just a decrease in incontinence episodes, 55%, 44% placebo, 53%, 37% placebo, and 55% with 40% placebo. This is mirabegron 25. So you look at those and you say, well, yeah, I guess it's not really as good as the antimuscarinics. If you look at the drug placebo ratios for the 2 antimuscarinics that we already reviewed and mirabegron, you can see that basically the drug placebo ratios are a little lower than they are with the antimuscarinics. And I feel like Chris does, I don't think that they work quite as well. This is an article that Chris did about real practice, looking at a number of parameters. It's like really busy. So let's just take the incontinence decrease. Let's look at placebo, just as high as we said. This is mirabegron 25, mirabegron 50, solifenacin 5, and terodoline extended release. So here are the drug placebo ratios, mirabegron, solifenacin, terodoline. So solifenacin at least has a better drug placebo ratio than mirabegron. Interestingly, these are the side effects from that series. You can see the only one that was significantly different, basically for the antimuscarinics and the beta-3s, was dry mouth. Constipation was not that much different. Mirabegron persistence, well, a little more persistent, so okay, if it has fewer side effects, I guess that's what you would expect. The side effects of mirabegron, This is the killer, hypertension. Now, just think about this a second, okay? In any trial, you know that 5% of the results are going to be a little odd. So placebo, this is the hypertension, very strict definition of hypertension. This is mirabegron 50, same as placebo. This is mirabegron 25. That's why it's in the PI that hypertension's a risk, and that you should follow these patients by having their blood pressure checked periodically. Did I do that with mirabegron? I told them to go to their GP. I don't want to come back to the office and waste an office visit to check their blood pressure, or go buy a monitor and check it, yourself. What this says basically is that most of the studies, including the study that Chris did, do not show a difference in hypertension between antimuscarinics and mirabegron. In other words, the incidence in Chris's series, I think, was basically 1%, and that was in elderly patients. So I'm not sure that the hypertension business, that's the same slide, is true, but the point is it's in the PI, so you have to do what it says unless sometime it's changed. Is mirabegron safe in the elderly? The qualitative answer basically is yes, and this is the EAU guideline, et cetera. Now this is interesting. Look what the EAU says. Solifenacin, darifenacin, fesoterodine, trospium have been shown not to cause cognitive dysfunction in elderly people in short-term studies. Short-term studies, not long-term studies. But it's interesting, and basically what that means is in all these studies, the drugs haven't been segmented. It's too bad. In other words, most of the most popular drugs, oxybutynin, so what you see in those big studies is mostly the effects of oxybutynin. So here are the guidelines for the beta-3 agonists, basically, both better than placebo. This says as effective as antimuscarinics. I'm not sure, looking at certain efficacy parameters, that's true. Adverse events, this is from the EAU guidelines, with mirabegron and vibegron are similar to placebo. Beta agonists in men, basically, they help. Same as with antimuscarinics. Maybe not quite as well, but you can use beta agonists in men with storage symptoms. So vibegron, basically, the newer drug on the market, it's selective. If you look in the laboratory, yeah, okay, it's more selective than mirabegron. There's more beta-2 activity, beta-1 activity with mirabegron than with vibegron. The maximum response at beta-3 receptors, basically, is a little greater with vibegron than mirabegron. Now, this is from a publication called the Medical Letter on Drugs and Therapeutics. Okay, this lists basically the differences between vibegron and mirabegron. So for vibegron, you can use in moderate liver disease. With mirabegron, it says you shouldn't. Same thing with renal disease. Moderate renal disease, okay. Mirabegron says no. Drug-drug interactions, says mirabegron has more drug-drug interactions than vibegron. Basically, you can summarize these differences, but this is the reference. No difference in results by age, no dosage adjustment for moderate renal disease or liver disease, minor induction or inhibitory effect on the cytochrome enzymes. It does increase digoxin maximal concentrations. So what's a drug-drug interaction? Well, a lot of people don't think about that. I'm not sure I've ever seen one, but I'm sure they've occurred in my practice. So this is basically a pretty decent article if you're looking for an article about this. And so this is the summary. Drug-drug interactions result in unintended reactions, toxic side effects, or a lack of clinical efficacy in individuals when multiple medications are simultaneously administered. The pharmacologic effect, or one or couple drugs, may be enhanced or suppressed, or a new and unanticipated adverse event may occur, even leading to fatal consequences. This was the original data about vibegron presented in the Journal of Urology in tabular form. Unfortunately, they were just bar graphs with no numbers down here, so you couldn't really tell exactly what the percents were. So this was the side effect profile, hypertension, no difference between drug and placebo. These are the true ratios from what was submitted basically to the FDA. So let's just look at urgency urinary incontinence reduction. 58.8% versus 40%, drug placebo ratio 1.47. Let's look at urgency, okay? 33% reduction in urgency. Now, none of the drugs, amazingly enough, reduce urgency, that much. And this is the placebo effect, so a low drug placebo effect. This is voided volume, basically. Voided volume is maybe the most accurate indicator, but as you can see, the drug placebo ratio is pretty high. So mirabegron's been shown basically, yep, it works in people. There's an extension study that shows you it doesn't go down particularly at 52 weeks. It works in elderly people, and it raises quality of life. Are there comparisons between the two? Well, here are two articles, okay? This is one review. I wanted to know why they eliminated the 40 out of 49 records. Okay, I don't know, because it doesn't really say. Interestingly, in this article, hypertension was the same in both drugs, mirabegron and vibegron. This is basically the chart that looks at this favored mirabegron. Here's the other study, basically in the Far East, looking at, this was only a 50 milligram dose of vibegron versus 50 milligrams of mirabegron, and there was no significant difference. Well, let's do the drug placebo ratios on what was submitted to the FDA, okay? So here's mirabegron, and here's vibegron. And, just as Chris said, hey, there's not a lot of difference if you look at this, is there? Except maybe for voided volume. Here's a big drug placebo difference with voided volume, and yet the absolute difference is really about the same. So what's that mean? Just means that for whatever reason, the placebo effect in this group was pretty small. So which drug, which class? This is one opinion in something called Up to Date. And basically what these people said was, look, when I have a choice between the two classes, I would rather use a beta-3 than an antimuscarinic because of the lack of side effects. They considered the two therapeutically about equal. They did avoid mirabegron in individuals with poorly controlled hypertension or who developed new hypertension. But as I said, in a lot of the other studies, the incidence of hypertension in the two groups, mirabegron, vibegron, has really been about the same. Alpha agonists, they do work in men, especially if they're combined with something to treat filling storage symptoms. There's no evidence that just giving an alpha blocker is effective in patients with only storage symptoms, and it has been pretty ineffective in women. This is basically what you can expect, with an alpha blocker, and it can reduce both storage and voiding symptoms. Phosphodiesterase inhibitors, especially PDE5, if you inhibit the transition of cyclic GMP, here the metabolism, then you'll get a persistence of the vasodilatory effects, which basically is what you get. And this does improve at least the AUA and IPSS, that is the symptom score. So the recommendation of the EAU is to use phosphodiesterase inhibitors in men with moderate to severe LUTs. And you should be able to use any of them. There's no reason. This one's approved in the US for BPH, but actually the rest of them should be. And why do they decrease male LUTs? Well, I don't know. These are all possibilities. Estrogen, oral estrogen, if anything, is going to increase incontinence. Local estrogen, vaginal creams have been reported to improve incontinence and certainly improve the symptoms of genitourinary symptom of menopause, of which OAB can be a component. So the EAU says offer that to women with LUTs, postmenopausal women, and associated symptoms of GSM. So what have we learned? Different ways to look at efficacy. Basically, the difference between drug and placebo, that's the actual drug effect. Look at the drug-placebo ratio. The drug plus placebo is what the patient actually experiences. Means are different from medians. Results are all over the board. Drug-placebo ratios is one way of looking at these. For each type of drug, there appears to be a ceiling effect, and there may be a ceiling effect for all overactive bladder drugs. In other words, for the oral drugs, there may be a ceiling effect that you're just not going to be able to go over. And in order for something to be significantly better, to say it is, it's got to be significantly better with those parameters. Here's another question raised. This is a new slide. Basically, I just made this because this just came out last month in the Journal of Urology. Step therapy, is that really justified, starting with oxybutynin and going up for the benefit of the patient? You know, my vote is no. So, thank you so much.
Thank you, Alan. Now we're going to talk about, Chris Chappell is going to talk about combination therapy for overactive bladder, and I urge you to follow this talk because there's a lot of combinations that he's going to talk about.
Thanks a lot, Eric. And, you know, it's amazing what placebo is, isn't it? I've always wondered about it, but one of the things that always occurred to me is often in these trials, it's the first time the patients had a bladder diary. A number of years ago, I did a secondary analysis on a study with Sender Hirschhorn, and we found that in the placebo group, the patients reduced their fluid intake, and in the active treatment, they increased it. Interesting. Because bladder diary is a form of bladder training. Because for the first time, the patient's actually seeing. You know, I remember a patient who was a professor in the university who had had Botox and everything. I did a bladder diary, he was drinking 4.5 liters a day and about 2 liters of coffee. He stopped that and he was cured. Okay, so what you're trying to do is to look with any drug at dealing with the relentless course of a condition which is chronic and which is going to potentially worsen. That's what we're talking about with the bladder. And what you're trying to do is reverse that process but not produce side effects which makes the quality of life worse. And obviously the principle is to address the situation by using 2 drugs with different modes of action. And where hopefully you can, by using a dose which is going to be additive without increasing side effects, possibly by reducing, for instance, the dose of anticholinergic, as an example, that you can try and improve the matter. And so certainly you've got to think of mechanism of action, efficacy, adverse events. So beta-3 and antimuscarinic, it's one that's been publicized recently. The principle, as you know, of course, it's the sensory mode of action of the beta-3, as we've already mentioned, and how by using these different effects that you can actually achieve that. A number of studies have looked at the combination, involving quite a lot of work, and an early study was the Symphony study, which looked with solifenacin as an example at 2.5 and 5 and 10 milligrams, and basically looking at combination with mirabegron at different doses. And they came to the conclusion that 5 milligrams of solifenacin, and remember, in the rest of the world, mostly, we don't use 25 milligrams except with renal function deterioration or hepatic dysfunction, and I've never had any trouble using 50 milligrams. Even in Japan, where they normally use half the dose of everything else, they use 50 milligrams. It's just because the regulatory authorities had a concern. So certainly 50 milligrams of mirabegron was pretty well chosen, and that led on to the Beside study, and basically what they tried to do was to have a superiority study which failed, and so they came to non-inferiority basically. So adding mirabegron to solifenacin 5 milligrams, that's 50 plus 5, further improved OAB symptoms versus solifenacin 5 or 10. And you can see that is suggested there. That's reduction in the sort of issues relating to quality of life. And this is dealing with incontinence. You can see that. This is dealing with micturitions. And you can see maximum incontinence episodes. But again, the effects are fairly marginal, and these are the statistical analyses which couldn't show superiority. So in a sense, it was a failed study because it was actually designed as a superiority study. Adding mirabegron to solifenacin associated with measurable improvements in health-related quality of life, so patients felt better. And you can see adding mirabegron to solifenacin associated with a clinically marked meaning improvement in symptom bother and patients' perception of bladder condition. Side effect profile, as we've already heard from Alan, there wasn't a great difference from the beta-3 over the antimuscarinic, and certainly you can see there wasn't a significant effect on pulse rate or blood pressure. With mirabegron, it's only meant to be contraindicated with a systolic blood pressure over 150 combined with a diastolic of 110, so quite a significant hypertension situation. Just to mention, we've heard a lot about the antimuscarinics, but remember that oxybutynin is not a pure antimuscarinic. It's actually a dirty drug. It's also got local anesthetic properties and other acts. It's a mixed action drug like propivorine. So conclusion was that combination did have some advantages, and I think many people do use this as a sort of intermediate approach after somebody's had a meaningful benefit, whether you start with a beta-3 or with an antimuscarinic, you add one to the other. And in clinical practice, it can be useful. We've all seen that. Vibegron, there was a study, this is not a powered study, but there was a study where they actually had a limb which actually had solifenacin as well, and really didn't show any big difference. But this is not a powered study. You can't really comment. I'm putting it there for completeness. But certainly, again, the beta-3 didn't have much in the way of side effects, and that's what they conclude. Over many years, one of the first combinations was an alpha blocker, 5-alpha reductase inhibitor, and certainly we've seen that. People have misused the data to say that dutasteride is better than finasteride, but remember the dutasteride was using a select population of patients, over 30-gram size prostates. There was a study from Curtis Nickel that showed dutasteride and finasteride from, I think, one of the big companies, nearly 1,000 in each group. They were identical drugs. So bear that in mind. But the downside I'm putting up here is to emphasize that if you take an alpha blocker and you take a 5-alpha reductase, you can see the increased effect on sexual function over either alone. So always bear that in mind. I've never seen any of the companies put up this slide, even though it's in the data set. You get adverse events if you add two drugs which are affecting, if you take a selective, an alpha selective agent such as tamsulosin, silodosin causes, it's 168-fold over tamsulosin for the alpha 1A, and certainly you get 25% problems with ejaculation and erections with silodosin. I don't think it's used in the States. Is it? Okay. But it's got a safer cardiovascular profile. But, you've just got to bear that in mind, I think it's fair to say. Okay, alpha blocker and antimuscarinic. And certainly this goes back to the voiding efficiency. Again, 120, 140 mils is taken as that 40% cutoff. It was never really emphasized at the time, but all the trials used that as a cutoff because when these trials were done, we were always worried about putting men on antimuscarinics because of putting them into retention. And this data has shown that you don't do that. Remember, 60% of men with bladder outlet obstruction have urodynamically proven detrusor overactivity, and more than that actually have overactive bladder, the storage symptoms. And so there is advantage you can see in looking at whether the predominant problem is storage or voiding. And again, if you look at data, you can see this very clearly shown that there is an advantage of the combination. Use of antimuscarinics alone, again, at the same time, people looked at that. And again, at the time it was controversial, but now it's well accepted. You can put a man on an antimuscarinic as long as they don't have a large post-voiding residual. And that's where the voiding inefficiency comes in, because if you start with somebody that's already got a residual more than 40% of the functional capacity, then of course it's going to inhibit the detrusor to some extent and may tip them into retention. It's sort of common sense, isn't it? Alpha blocker and antimuscarinic, therefore, combination has been now clearly established. Tamsulosin and solifenacin, there was a marketed combination, and the evidence is that there is some benefit. But to be honest, I think most of us just use the drugs not in combination, but adding one to the other. That's certainly my practice. And if you look, you can see here, the TOCUS is just a market extension of tamsulosin, trying to maintain the branded drug, which is said to have a slow release. Most of us have just used tamsulosin, and if you look there, if you're adding in solifenacin, you improve the benefit, and you can see that without a significant problem, but you can see the benefit of storage symptoms, quality of life improvement. Alpha blockers and beta-3, small studies which have shown this, but more recently a study from the States which has shown this, and you can see this did demonstrate some benefit, as you might expect. What I'm doing is going through things quite quickly because, you can spend a lot of time looking at the data, which you should do, but at the end of the day, it's what you'd expect, having looked at each of the individual drugs. There is benefit combining drugs, and you can see that shown here from this paper in the Journal of Urology. If you then go on to the PDE5 inhibitors, they seem to improve overactive bladder symptoms, and you can see here compared to tadalafil and tamsulosin, again thought to be due to sensory mechanisms, poorly defined, nobody's really sure, but there is good evidence, and you can see therefore with a meta-analysis of tadalafil, that's been shown, so no surprise, you can do alpha blocker and PDE5 inhibitor, and there's certainly a combination. There is some evidence, but you can see it's not high quality evidence. You've got the 5-alpha reductase and PDE5. Theory here is if you're getting the 5-alpha reductase causing problems with sexual function, the PDE5 may improve it by counteracting that. That's the suggestion. Again, small studies showing that there is a benefit. Beta-3 agonist and PDE5, you can see every combination's been tried, but outside the studies which are used as pivotal studies to get a market license, they're all small numbers, and again, you've got to take them as they stand with small numbers. And you can see this randomized study here, but again, it's fairly small numbers, but again, showing a benefit. So I've tried to pull out from the literature what exists, just to show that there is no doubt that combination therapy may be advantageous. You've got to think of the side effect profile, and you've got to think of what you're trying to achieve. So ultimately, that's what you're doing. You think of every possible combination. And at the end of the day, whether it's male or female, what you're trying to do is to think of all of the other effects in the body the drugs may have, what the underlying pathophysiology is, and then trying to use it on a personalized basis in an individual patient to improve ultimately their quality of life. It's not a matter of cure, unfortunately, because you stop any of these drugs, their symptoms will revert, although we all know patients who've been on treatment and their symptoms seem to get better, again, due to other factors. Thank you very much.
All right, we're going to switch topics slightly to nocturia, and although it's not, nocturia is not a individual symptom, or is an individual symptom of overactive bladder, I'm going to treat it as a condition in and of itself, even though it is a component of overactive bladder. So we'll talk about some monotherapy and combination therapy for nocturia. Nocturia is the most prevalent lower urinary tract symptom. I don't remember whether Chris or Alan already showed you this slide, but of all the lower urinary tract symptoms, filling and voiding and storage and voiding symptoms, nocturia is the most common symptom. Bothersomeness, as we measure bothersomeness in large population studies, seems to occur when nocturia is occurring 2 or more times. ICS defines nocturia as waking up 1 or more times at night, so you have to wake up, go to the bathroom, go back to sleep. So if you go to the bathroom 5 times watching the 11 o'clock news, then you go to sleep and sleep the whole night, your nocturia is 0. 3 broad categories for nocturia, only one is relevant to this talk. So you can wake up at night because you drink too much, polyuria, leading to polydipsia. You can have bladder storage problems, overactive bladder. You can have BPH or BPE or obstruction resulting in distributed overactivity, or you can have nocturnal polyuria. That's the one relevant to this talk, is nocturnal polyuria. And of course, you could have non-urologic problems such as a primary sleep disorder. And if we take those categories and we break them down, polyuria is caused by polydipsia, and bladder storage problems are caused by overactive bladder, a variety of other things. And then there's nocturnal polyuria. Lots of drugs have been looked at. That long laundry list that you just heard for the last hour of antimuscarinics, beta-3s, alpha blockers, PDE5s, have all been looked at for nocturia, and all have failed, either as a primary analysis or a secondary analysis. And you'd say, why? Well, Here, monotherapy, lots of different drugs have been used. Antimuscarinics, beta-3s, alpha blockers, PDE5s have all been looked at as monotherapy for nocturia. Here's just a brief list, and if you look real hard, the reduction in number of voids per night for these agents as monotherapy for nocturia, the results are pretty miserable. And you'd say, well, why? I use alpha blockers for my BPH patients and they get their nocturia gets a little bit better. Well, the problem is when you do these studies in large populations, you're not selecting your patients with nocturnal polyuria, which is the #1 cause of nocturia. You're treating virtually everybody, and you're not selecting the patients who would respond. So nocturnal polyuria is not going to respond to an alpha blocker or a PDE5. Similarly, if you use combination therapy for nocturia, again, lots of studies have looked at therapy for nocturia with combination therapy, as Chris talked about. It doesn't work very well unless you eliminate patients with nocturnal polyuria, because nocturnal polyuria represents the largest group of patients with nocturia. You're not treating nocturnal polyuria with alpha blockers or antimuscarinics. So it's pretty clear. That was a lead into this slide, which is really 3 different prevalence studies looking at the prevalence of nocturia, of nocturnal polyuria in patients who have nocturia. And it doesn't matter whether you're in Europe, Japan, or the US, the majority of patients with nocturia have nocturnal polyuria. So you have to treat the nocturnal polyuria to treat the nocturia, not the other problems that they may have. And as Chris talked about earlier, there's only really one way to assess nocturia. That's with a voiding diary. This is my own voiding diary that I use. It's not any better or worse than anybody else's diary. But a voiding diary is just a record of how much and how often the patient urinates. Yes, I do make my patients with nocturia fill out a diary. If they want to get better, that's the way to get better, is to make sure that they have nocturnal polyuria. Even though the majority do, I want to prove it to them so then we can discuss rational therapy. Nocturnal urine volume is the amount of urine the patient makes after the first time they go to sleep until they wake up, including the first void of the morning. That's all of their overnight urine production. And then from that, you can get a nocturnal polyuria index, which is very simply the amount of urine that they make overnight divided by the total urine volume for 24 hours. A normal person, because of things we're going to talk about, vasopressin, among other things, that normal volume should be, in a normal person, less than 33% of their 24-hour volume. You should make less than a third of your urine overnight to not have nocturnal polyuria. That's a normal person. If you make more than a third, you have nocturnal polyuria. So this is a patient with, this is a diary, I'm sorry it doesn't project very well, but this is a diary of a patient who goes to the bathroom frequently and has nocturia. What do they have? Well, they have the same volumes during the day and the same frequency during the day that they have at night. They're making 2 or 3 ounces every void. This person doesn't really have nocturnal polyuria. They have overactive bladder. They have to be treated for their overactive bladder. This is a patient who drinks too much. No matter what I do this patient, whatever drug I give them, as Chris said, the professor who drank 4.5 liters, I can give him all the drugs in the world. He's not going to get better. I have to tell him to restrict the fluids that they're drinking during the day to treat their voiding dysfunction. This person has nocturnal polyuria. Let me show you why. There's their nocturnal volumes from the time they went to sleep to the time they woke up. 300, 400, 350, and then their daytime volumes are 70, 70, and 75. So this person makes about 60 to 70% of their urine at night. I can give them all the BPH drugs and overactive bladder drugs in the world. That's not going to fix that. And the only way to diagnose that is with a diary. This is a patient who basically has both overactive bladder and nocturnal polyuria. They're making about 1,300 cc's overnight. That's a lot of urine overnight. And during the day, they're making small volume voids. So this patient needs treatment for both overactive bladder and nocturnal polyuria. So what is the etiology of nocturnal polyuria? There's lots of different ones. Patients who take their diuretics at night, patients who drink a 6-pack of beer before they go to bed, patients who have 6 cups of coffee before they go to bed, patients who eat a bag of potato chips and drink water before they go to bed. Those are all causes, behavioral causes of nocturnal polyuria. They are easily fixed. And then there are medical conditions and things like sleep disorders where urologists, I don't treat sleep disorders, but I send them to a sleep center. But congestive heart failure, renal failure, obstructive sleep apnea, all these other biological causes, if you will, of nocturnal polyuria, I don't treat. The one that's relevant to us as urologists, as people who treat patients with nocturnal polyuria, is actually the hormonal causes. And that's related to arginine vasopressin, something that you all learned about in medical school and are very familiar with, otherwise known as antidiuretic hormones. Antidiuretic hormone, something released from the posterior pituitary, and as well as atrial natriuretic peptide released from the heart in response to various pulmonary conditions. These are the two hormonal causes of nocturnal polyuria. Treatment for nocturnal polyuria starts with behavioral things that I showed you earlier that you can fix, diuretics and fluid restriction and things of that sort, lower extremity edema, fixing lower extremity edema either with leg elevation or compression hose, and then treating their medical illness, which of course as a urologist, I don't treat their medical illness. I send them to their family doctor and I tell them if you treat their COPD or their obstructive sleep apnea or their renal disease, maybe we can make their nocturia better. But let's get back to the hormonal causes, which are not really urological, but they're things that urologists treat. Arginine vasopressin, AVP, antidiuretic hormone, is released from the posterior pituitary, generally and physiologically in response to changes in plasma osmotic pressure, not oncotic pressure. It actually acts at two different receptors, a V1 receptor and a V2 receptor. The V1 receptors are located in the vascular bed and in the uterus. V2 receptors are located in the kidney. And if you take the agent, the arginine vasopressin, as an agonist of the V2 receptor, what happens is it causes free water absorption in the medulla of the kidney. What does free water absorption result in? Less urine output. Okay? The reason that happens, or the physiologic mechanism, is the V2 receptor causes a fusion of something called an aquaporin molecule to the luminal side of the collecting duct, which causes free water reabsorption in the medulla. This is the best cartoon I've ever seen. I'm not a renal physiologist, but this is the best cartoon I've ever seen for describing actually what AVP or antidiuretic hormone does in the kidney. And what you see here is collecting the glomerulus, descending, ascending, and then collecting tubule. This is a normal nephron. Under the influence of DDAVP, what you get is free water absorption in the collecting, and you get a small volume of very concentrated urine. And that's what's supposed to happen at night. We make less urine at night. Desmopressin acetate, DDAVP, is a construct of AVP which lasts longer. It is an engineered form, a synthetic analog of arginine vasopressin. Arginine vasopressin lasts in the serum just for seconds. It's not a useful physiologic molecule to give on a daily basis, so this is a synthetic analog that lasts longer. It lasts several hours. It is a V2 receptor agonist, meaning it has very little effect on vascular beds, very little effect on the uterus at V1 receptors, really only works on V2. It increases urine osmolality and decreases urine volume. Desmopressin gets an A rating from the International Consultation on Incontinence. Alan showed you this earlier. It does cause considerable adverse events, the most famous of which is hyponatremia. There is a substantial risk of hyponatremia. I will show you that shortly. That risk of hyponatremia is tied strongly to age. It is much more of a risk in the elderly than in the young. It is also tightly tied to a low sodium at baseline and then excessive fluid intake in the evening. The key about that hyponatremia is if it doesn't happen in the first few days, it doesn't mean it's not going to happen weeks or months later. So this requires long-term monitoring of sodium levels. The EAU has very particular guidelines at 3 and 7 and 30 days, and then several times a year you should measure patients' serum sodium despite chronic use of DDAVP. So how well does it work? This is a systemic review. Roughly, you're going to reduce 3/4 to 1 void per night over placebo. The key of this drug, or this agent, is that it decreases urine volume at night, so it increases the time to your first awakening to void. And that's your highest quality of sleep. So from the patient's perspective, getting that first void a longer interval is of great importance for their quality of life. So that's the mechanism of this improving quality of life, is the increase in sleep prior to the first time that you wake up to void. What is the incidence of hyponatremia? In one large meta-analysis, it was 7.6%. That's pretty high. All right, so that's why you have to monitor these patients. I told you the risk factors: a low sodium at baseline. Women are at slightly increased risk than men. Patients with cardiac disease and renal disease. Also concomitant drug use, steroids, either inhaled or systemic steroids, and loop diuretics also increase your risk of hyponatremia. The drug is actually contraindicated with concomitant use of loop diuretics or corticosteroids. Again, monitoring sodium, this is not the European guidelines. This is suggested from that original paper, roughly checking a baseline sodium, and then at 4 days after starting therapy, 28 days, and then about every 6 months. So an interesting study that came out very recently looked at, I just showed you a bunch of contraindications to DDAVP. So how many people can actually safely benefit from DDAVP for nocturia? And this was a big analysis of over 4,000 patients from the National Health and Nutrition Examination Survey. Lots of publications out of this data set. But they reviewed basically all the comorbidities of all these 4,000 patients entered in, and they did an analysis of how many patients could actually safely take DDAVP based on their medical history. And as you can see, there were prescribing concerns in 80% of patients in this study, of which almost 42% took a concomitant drug that could increase the risk of low serum sodium, and 50% of these patients had outright contraindications to DDAVP use. So if you're careful in who you choose your DDAVP patients, it's actually a very small number to safely give DDAVP. There's multiple different formulations for DDAVP. They're oral tablets, most commonly used. There's a nasal spray. The company that produced the nasal spray, the nasal spray has been discontinued temporarily. I don't have any further information for you. I should say the newest form of the nasal spray, which was known as Noctiva, it allegedly led to improved biocompatibility, which led to lower rates of hyponatremia, but the drug is no longer on the market. There's also an oral disintegrating tablet known as Nocturna. The, quote, melt formulation also allows lower dosing and potentially less risk of hyponatremia. This is the data from the Noctiva trials. The gray represents the placebo. The orange is the low dose of Noctiva. The blue is the high dose of Noctiva. And you can see if you do the drug placebo ratios like Alan suggests, the effect is not fantastic, but there is a reduction, a substantial reduction, at least of 1 night plus placebo, 1 episode plus as compared to placebo. I'm going to skip this. Reduction in urine volume is actually what we're after for these drugs. So this is the actual data from, again, the study looking at reduction in urine volume. If you look at placebo versus the high dose, there is a substantial difference in urine volume with DDAVP as Noctiva. That's the incidence of hyponatremia. Couple of thoughts about combination therapy. I know Chris covered a lot of this. There's no reason why you couldn't combine DDAVP with patients or in patients who have other concomitant lower urinary tract problems. Nocturnal polyuria occurs, as I showed you in those diaries, in combination with other lower urinary tract pathology. So there's no reason why you couldn't. For example, this is a study that we did a number of years ago looking at women with overactive bladder and nocturia. And they were randomized to tolterodine with or without DDAVP. It's a 12-week trial. I'll skip through this very quickly, but the point here is that these are women with a combined disorder. And if you look at combination therapy versus monotherapy, the blue versus the orange, what you'll see is that there was a substantial reduction in nocturia in both groups. The real difference was if you culled out the women who didn't have nocturnal polyuria. So now we're looking at the patients in whom DDAVP actually works on. You get a substantial difference between patients on placebo and drug, because you are actually now treating the patients who have the condition for which DDAVP will treat. So combination therapy, if you select the patients properly, you will get a good response in combination therapy. I'm going to skip through that. And then the same goes for DDAVP in patients with males with lower urinary tract symptoms. Studies have been done looking at BPH and nocturia and nocturnal polyuria. There's just a couple of studies that show an increased efficacy for nocturia if you have combination therapy in patients with BPH and nocturnal polyuria. Same thing for patients with overactive bladder. Just a word on future pharmacotherapies for nocturia. This is a drug that was very exciting a couple of years ago, Vapagon, which was another V2 receptor agonist. They actually had a successful phase 2, phase 3 RCT with improved nocturnal voids from baseline, improvement in time in first void, reduction in nightly voids by 50%. I could not find anything in further about this drug. It just says that the development was discontinued in September 2021. The interesting thing, the thought was that this was a longer acting drug than DDAVP, which is why they had perhaps better efficacy, but on the downside, and I don't have any independent confirmation of this, if you have a longer acting drug, then your risk of hyponatremia is also going up, and that perhaps is why the drug was discontinued. There are a couple of other small molecule V2 receptor agonists in development. I don't have any other further information on those, so maybe we'll hear more about that in the future. There was some interest in a drug called Paxerol a couple years ago. Paxerol is a combination of acetaminophen and a non-steroidal anti-inflammatory. Non-steroidal anti-inflammatories actually have a couple of physiologic properties in the urinary tract. They do, to some degree, reduce urine production, reduce detrusor muscle tone and inflammation, at least in men with BPH. So this was a very, very small study, a phase 2 study of 86 patients, looking with a mean number of 2.5 nocturnal voids, and actually this combination agent, which again, acetaminophen and ibuprofen, actually had a pretty good effect in a very small number of patients in a 4-way trial. Have not heard much more about Paxerol for nocturia and nocturnal polyuria. So, conclusions. Nocturia is the most common lower urinary tract symptom, may or may not be related to overactive bladder. There's 3 causes: behavioral, bladder storage problems, and hormonal problems. Your diary is your key. Your diary is your key. Your diary is your key. Treatments based on the underlying cause. DDAVP is the primary treatment for nocturnal polyuria, for nocturia due to nocturnal polyuria, and beware that just because they have one lower urinary tract condition doesn't mean they also don't have nocturnal polyuria. Thank you. And we'll move on to future pharmacotherapies with Alan.
Thank you. So, possibilities for future pharmacologic therapy, conflict of interest. So, you win the lottery, all right, for $1 billion. You want to go out and develop a drug. So, what do you have to do? Well, first of all, you need a pharmacologic rationale. Okay, why should, if you're going to develop a particular product, why should it work? Then you need to get some animals, and you're going to need to get some tissue in vitro and see if it produces the desired effect. Then you need to study some animals in vivo, mostly little furry animals, to see if it works. Then you need to do a toxicology study in real people. Then you need to do a phase 1 trial, a phase 2 trial, a phase 3 trial, and basically then you submit it to the FDA. So, 2 articles about the success of drugs going on to clinical trials, and this is for each one. As you can see, your likelihood of making more money is not terribly great. Here's another one. Look at other than oncology. So the probability of getting to phase 1 is 21%. If you do that, getting through phase 2, 27, et cetera, et cetera, et cetera. So difficult to do. Potential management strategies, we've already done that. Possible sites of action, anywhere from the brain down to the detrusor smooth muscle. Drugs can affect release, binding, transduction steps, metabolism of any agonist or antagonist. Some pretty pictures. Drugs can act on basically the afferent side, sensory side that is. They can act on the motor side. Again, just a pretty picture. They can act on the afferent side back to the CNS. They can act on the efferent side through the CNS or actually down as far as the smooth muscle of the bladder. They can act on the urothelial cells. They can act on the lamina propria. They can act on the muscle. And again, some pretty pictures from the book Incontinence, which actually you can download in slide form. So they can act on the urothelium. They can act on the interstitial cells. The problem is always going to be uroselectivity. Are there any other possibilities for antimuscarinics? Well, in order to be better, they either have to be more effective, that is, exceed what's now the ceiling effect, or have fewer side effects. This was the problem with anticholinergics and cognitive dysfunction. We covered that. Are there other possibilities? Cannot find this drug anymore. This was an interesting product that combined an anticholinergic with a medication that stimulated salivary secretion. They had a phase 3 trial that was in progress that began in 2015. Haven't heard very much about it since. I can no longer find this one. In the book Incontinence, there are no other antimuscarinics for OAB in development that are mentioned. These drugs are not yet licensed in the US. Propivarine is an oxybutynin type drug. I'm not sure why someone hasn't tried to license it in the US. There have been very few studies done to the exhaustion of the studies in the US. Amatafenicin is a drug that's been tried in Japan. A few trials have shown, wow, it really has a very good effect. It's a combination drug. Like Chris says, it's a little bit of a dirty drug, not just a pure antimuscarinic, supposedly a lower dry mouth than solifenicin. Hasn't really been subjected to any comparative studies or what we would consider good placebo studies. Beta-3 adrenergic agonists are going to have to be better than the two out there. Phase 3 studies not yet done for this one. I mean, this has been around now for years, and when something's been around for years and you see no new stuff, you can say, well, yeah, okay. This is an interesting story. This is what happens, basically. Here's a drug, pharmacologic rationale. Yep, it's a beta-3 agonist. It's pretty selective, limited effect on heart rate or blood pressure. Got up to phase 3 trials, so they've already spent a lot of money. Primary efficacy endpoint, which was frequency, not met. So goodbye, ribagron. So this is basically the chronology. This was the phase 1. It increased the volume at first contraction, basically, and this was a quote. The other studies actually weren't published, but someone who was involved basically did publish this comment. It seems that the primary efficacy endpoint was not met. So there are a few others in the pipeline. These are all the numbers. There are really 3 possibilities for action. I don't think anybody really knows exactly how these work. There's an afferent side, there's an efferent side. Is there a ceiling effect? Well, probably there is. What's going to make another one superior to the 2 on the market? This was listed in these publications as in development. I couldn't really find any of these anymore. So I think that these references are probably old. PDE5 inhibitors in men, as I said, there's no reason why you can't use these either. Why do these work? Don't know. These are all the other possibilities. But is there going to be one that is more selective or better works than tadalafil? I don't think so. Potassium channel openers haven't worked really because of side effects on heart and blood pressure and not very good clinical results. Calcium channel antagonists, really the same thing. I call them great ideas that just didn't work for one reason or another. Prostanoid receptor antagonists, again, great idea that didn't work. promising animal models, mediocre clinical results with a high incidence of adverse effects. New targets with positive results. Duloxetine, the drug for stress incontinence, actually gave surprisingly good results in women with overactive bladder, but there were too many adverse events. Nausea, that was the placebo for nausea, dizziness, insomnia, fatigue. So basically that was dumped as an idea for duloxetine. Vitamin D antagonists, minimally positive clinically effects. Neurokinin receptor antagonists, again, nice idea. I'll take you through this one. The neurokinin 1 receptor antagonists, people use these for actually antiemetics in the hospital. They block capsaicin-induced detrusor overactivity. So neurokinin story, there was a drug called Arepitant that was used for chemotherapy-induced nausea that significantly improved OAB symptoms. I put significantly in quotes because you might not consider it significantly. Unfortunately, that drug had a lot of issues with drug-drug interactions. Another drug was developed pretty similar. They compared it to tolterodine. Tolterodine was superior in all doses of the drug, and the drug was dropped. GABA is the chief inhibitory compound in the central nervous system. There is a drug that's a selective modulator of this. You know, the usual story, promising effects in little furry animals, and the quote is, further studies would be of interest. Purinergic possibilities. In the normal bladder, there's a minor contribution to contraction by ATP. In disease states, that changes to up to 50% of the contraction. And ATP basically is released, as Chris said, from the urothelium in response to filling. So it's a sensory neurotransmitter. And there are P2X3 receptors expressed on bladder afferent terminals. And also, if you make a knockout mice, basically for this receptor, you will see that you decrease frequency, you reduce peak pressure in response to filling, but you don't change the effect, you don't change the magnitude of emptying contraction. So wow, what a great idea. You decrease sensation, but don't disturb voluntary voiding. And these were from the little furry animals. Basically, this is basically total volume, so you can fill it more. This was frequency, it decreases, but the amplitude of an emptying contraction doesn't go down. Unfortunately, that drug, basically, you really haven't heard much about this. There was one publication that was back in 2015, actually, in the ICS. It was an abstract, and I haven't seen much of it since. Cannabinoids, boy, wouldn't that be great if you could use those for overactive bladder? Wow, we'd all take them regardless, right? Because we'd make up, hey, I got overactive bladder, I need that. Well, in reality, little clinical data. This was a quote from a fairly good article. The evidence base is poor, more high quality, well designed, and adequately powered, and sampled studies are urgently needed to reach definitive conclusions. Urgently needed, that was in 2017. Transient receptor modulation, these are receptors involved in nociception and mechanosensory transduction in various organs. And again, wow, same story. So it increases filling but doesn't change the amplitude of an emptying contraction. In humans, this one actually produced hyperthermia, so can't use it. This one was called a successful failure, okay? So successful failure means to me the operation worked, but the patient died, all right? I mean, so basically this one's not used, and this was a great quote from a couple years ago. I don't think things have changed. In conclusion, TRP receptors are a reality that still needs an enormous amount of work and dedication before becoming therapeutically useful, and that may take more time than we anticipate at the moment. Opioid receptors. The mu receptor may modulate micturition, and here's one that was published. Look what this is, oxybutynin added to an in vitro bath. This is this mu opioid receptor ligand, basically. Look what it does, and I haven't heard anything more of this, but it's a possibility. There are drugs that reduce fibrosis, let's say in response to obstruction, so that may reduce the appearance of overactive bladder. Unfortunately, these drugs cause severe cardiovascular reactions and mortality in animals, so they were never used basically in humans. Other ideas basically are listed here. Again, they all start out with a pharmacologic rationale that's pretty good, but they never seem, or they haven't seemed to advance, further. This is a new idea that Eric published on. You'll hear about it tomorrow. It involves injection, basically, of a gene therapy plasma vector expressing the human big potassium channel alpha subunit. The preliminary studies were very promising. Basically, if you want to read about this, this is a great article that was first authored by Carl Eric Anderson. This is the journal. So if you're interested in this, want to read about it, there'll be some phase 2 results presented tomorrow in terms of the quick or the late breaking abstract. So summary, you can do this, you can combine drugs, like Chris said, you can combine drugs with other form of treatments, you can use new variants of currently accepted principles, try that. These are the new targets that are positive, but unfortunately, I think that the logical conclusion is that there are many old targets and some new targets and some promising animal data, but there's no new currently clinically successful breakthroughs that have been approved by the FDA. Thank you.
Thank you for waiting until the very end. We'll stay around to take some questions. I realize we went over. We tried to stay on time, but we do appreciate your patience and take any questions.
Is this working? Just my observation first before I ask the question. I have been in practice for almost like 20 years. I have a very active urodynamic lab. And I have, over the years, I have been involved in doing TERPs for obstruction-related overactive bladders. I've done PTNS, nerve stimulations. I was involved with Rick Schmidt for a million of those sacral nerve stimulators. But, my observation is that there are certain people who just have structural or functional setup that they're going to have overactive bladder, and why those people do and why others don't. And when I sometimes compare urodynamic findings, say somebody I did 6 years ago, and 6 years later, I certainly see deterioration no matter what they had done. They could have done nerve stimulators over the years, they could have done TERP, they could have done any kind of treatment. I see constant deterioration. The bladder size becomes smaller, overactivity is more, sensory urgency, and their symptoms are worse. So, it seemed like I go back to 30 years ago when I was a student in Edinburgh, that basically what I learned as a student, that these people have their system upregulated, both chemically and structurally. And all these treatments do not target on any of that. Gene therapy would be, and I appreciate that article seemed like intriguing, but all the treatment targets are alleviating the symptoms. And none of this truly targets what the pathophysiology is underneath. And I just wonder if anything in that direction we're doing. So it's more of a research question rather than a truly clinician question. Because in urology, everything we fix, this is something I don't think we can fix.
I'll say, so Chris used to have a great slide that he took out this year, and it was the human and all the different things that contribute to the lower urinary tract symptoms. Like I said very early, the urinary tract is not like cheese and fine wine, right? So it doesn't get better with age, but also all of those comorbidities, that patient you did TERP on 6 years ago is now 6 years older, right? So he's got, Chris alluded to it, he probably has some clinical neurologic disease that he didn't have 6 years ago, and maybe his diabetes is a little bit worse, and maybe he's a little fatter, and a little metabolic syndrome. In addition, his bladder's contractility is not any better than it was 6 years ago. It's probably worse, and all those other factors have changed. So to some degree, I agree with you 100%. None of these targets are addressing all of the things I just mentioned, and they're not addressing whatever other pathophysiology is happening that's causing those symptoms to get worse over time. And maybe the gene therapy will be something, but that's really also not targeting a specific etiology either. It's sort of putting a patch on it. Chris, do you have anything to add?
You raise a very valid point, and it always reminds me of a study reported in the Journal of Urology about Chelfin and Bradley about 35 years ago, where they injected lidocaine into the prostate and doing urodynamics before and after, and the overactivity went away because the first thing you do with a TURP is to do a deafferentation, because the first thing you do is to cut out the urothelium within the prostate. And Paul Abrams has looked at that, and I think it was 10 to 15 years after TURP, the incidence of bladder overactivity was the same whether they had a TURP or not.
We're going to take the rest of the questions
Well,
out the door.
Thank you. Appreciate it.
Okay.